A soldier accepts risk the moment they raise their right hand. Bullets, bombs, bad luck, those are understood hazards. What they do not expect is risk handed to them as a policy memo. In the late 1990s, tens of thousands of American service members were ordered to take a vaccine, not because they were sick, not because an enemy had attacked, but because the government feared what might happen next. Refusal was not an option. Questioning the order was treated as disobedience. Careers ended over a syringe. For some, the shots came and went without issue. For others, the story did not end there. Years later, they would report symptoms they could not explain, injuries they could not prove, and a system that demanded evidence no one could provide. This is not a story about whether vaccines work. It's a story about trust, mandates, and what happens when the institution that demands obedience cannot or will not answer the consequences. Because once obedience becomes compulsory, responsibility should be automatic. And in this case, it wasn't. Anthrax has always occupied a special place in military thinking, not because it's the most exotic weapon, but because it's brutally simple. It is a naturally occurring bacterium that can be turned into something far more dangerous with little more than time, equipment, and intent. Inhaled anthrax does not need to explode, burn, or spread dramatically to be effective. It only needs to be breathed in once. Untreated, it kills quietly and efficiently. Treated too late, it still kills. For Cold War planners, that combination made anthrax terrifying. Unlike nuclear weapons, it did not require rare materials. Unlike nerve agents, it did not demand precision delivery. Unlike conventional weapons, it did not announce itself. A release could occur without warning, without detection, and without immediate attribution. By the time symptoms appeared, the exposure had already happened. That reality shaped decades of quiet contingency planning. By the 1950s, both the United States and the Soviet Union understood anthrax as a viable battlefield threat. The Soviets, in particular, invested heavily in biological weapons research, viewing it as a strategic equalizer. Intelligence reports throughout the Cold War suggested massive stockpiles and industrial-scale production capability. Whether every estimate was accurate mattered less than the perception. Anthrax was no longer hypothetical. That fear hardened into doctrine. Anthrax spores are extraordinarily durable. They can survive heat, cold, desiccation, and time itself. Properly prepared, they can remain viable for decades. From a military standpoint, that meant a weapon that could be stored, transported, and deployed without the fragility of other biological agents. It also meant something more uncomfortable. Once released, cleanup was nearly impossible. The infamous 1979 Sverdlovsk incident, where an accidental release from a Soviet military facility killed dozens, confirmed what planners already suspected. Anthrax did not need to be weaponized perfectly to be lethal. Even mistakes could be catastrophic. By the time the Cold War began to thaw, anthrax had already earned its reputation. Then came the Middle East. In the late 1980s and early 1990s, U.S. intelligence assessments increasingly focused on the biological weapons capabilities of Iraq under Saddam Hussein. Iraq had already used chemical weapons during the Iran-Iraq War. That fact alone reshaped how planners evaluated risk. A regime that had crossed that line once could cross another. Anthrax became part of the threat matrix almost by default. Whether Iraq possessed deployable anthrax weapons in 1990 mattered less than whether U.S. leadership believed it might. Military planning does not wait for certainty. It moves on probability, consequences, and worst-case outcomes. Anthrax fit neatly into all three. The problem was not just lethality, it was unpredictability. A biological attack would not look like a missile launch. There would be no radar warning, no incoming alert. Units could be exposed without ever knowing it. Symptoms might appear days later, scattered across formations with no clear cause. In a deployed force operating far from robust medical infrastructure, that scenario was unacceptable. So planners looked for a solution that did not rely on detection or response. They looked toward prevention. Vaccination offered something doctrine desperately wanted: control. If troops could be immunized in advance, then an invisible weapon became manageable. Exposure would no longer mean mass casualties. A silent attack would fail to achieve its objective. On paper, it was elegant. What that logic did not yet confront was the difference between preparing for a hypothetical battlefield and imposing certainty on real people. That tension between what might happen and what was being ordered in advance would define everything that followed. By the time the first syringes were uncapped, the anthrax threat had already done its work. Not on an enemy, on policy. And once fear hardens into doctrine, it rarely asks permission. Long before anthrax became a household word, a vaccine already existed, but it was never designed for the role it would eventually be forced to play. The original anthrax vaccine used by the United States traces back to the early Cold War, developed not for mass military use, but for a narrow occupational problem. Certain civilian workers, those handling animal hides, wool, or livestock, faced a real but limited risk of exposure to cutaneous anthrax. For them, vaccination made sense. The exposure pathway was known, the risk was localized, the population was small. That context matters. The vaccine that would later be injected into hundreds of thousands of service members was licensed in 1970, approved by the Food and Drug Administration for protection against anthrax infection. What it was not explicitly tested for or licensed to address was inhalational anthrax resulting from a battlefield aerosol attack. At the time, that distinction seemed academic. The threat profile was different. The mission was different. No one imagined force-wide mandates. The vaccine itself, Anthrax Vaccine Absorbed, was based on an older production model. It did not use live bacteria, but it relied on a filtered culture product intended to stimulate immunity against anthrax toxins. By civilian standards, it was considered effective enough for its intended purpose. By modern military standards, it was never stress tested for the role it would inherit. That gap would come back later. For decades, the vaccine lived quietly at the margins of public health. It was administered sparingly, monitored lightly, and largely ignored outside of specialized circles. There was no urgency to modernize it, no pressure to expand its use, and little incentive to conduct large-scale trials for hypothetical threats. Then the strategic environment changed. By the late 1980s, the United States military was re-examining threats that did not fit traditional Cold War templates. Chemical and biological weapons, cheap, deniable, and asymmetrical, moved from the theoretical concern to operational planning. Suddenly, a vaccine that had once protected tannery workers looked like a potential shield for entire divisions. The problem was that the science had not kept pace with the ambition. Testing for inhalational anthrax in humans was ethically impossible. That meant efficacy had to be inferred from animal studies, limited data, and extrapolation. Regulators accepted that approach within certain bounds, but those bounds were narrow. The original license did not explicitly contemplate mass immunization against weaponized anthrax spores. Inside regulatory language, that mattered. Outside it, planners saw a tool they could use. The Department of Defense viewed the vaccine through a risk management lens. Even partial protection was better than none. Even uncertainty was preferable to vulnerability. In a planning room, those arguments carry weight. Informed consent rarely enters the discussion at that stage. But vaccines are not abstract solutions. They are administered one person at a time. As long as the anthrax vaccine remained limited to small, voluntary populations, its imperfections stayed hidden. There was no large data set, no systemic stress, no reason for controversy. It existed in a gray zone, approved, accepted, and largely unquestioned. That would not last. Once the vaccine was pulled out of obscurity and placed at the center of force protection strategy, everything changed. Scale magnified scrutiny, mandates magnified resistance, and questions that had never needed answers suddenly demanded them. What exactly had this vaccine been approved to do? What evidence supported that approval? And who would bear the responsibility if those answers proved insufficient? Those questions were already embedded in the policy long before the first mandatory shot was given. They simply had not been asked out loud yet. They would be. When American forces began deploying in the Persian Gulf in 1990, they carried more than rifles and rations. They carried assumptions shaped by the last decade of intelligence failures and hard lessons. The central fear was not conventional combat, it was uncertainty. U.S. planners believed that Iraq possessed chemical weapons. That belief was not speculative. Iraq had used them openly against Iranian forces and Kurdish civilians in the 1980s. The precedent mattered. A regime that had already crossed one taboo could cross another. Biological weapons, including anthrax, sat squarely in that category. Whether Iraq actually intended to use anthrax was almost beside the point. Military planning does not operate on intent alone. It operates on capability, opportunity, and consequence. Anthrax checked all three boxes. The Gulf War presented a uniquely vulnerable scenario. Large numbers of U.S. and coalition troops were massed in fixed locations. Many lived in temporary encampments with limited environmental controls. Detection equipment for biological agents was rudimentary at best. If anthrax were released by missile, aircraft, or unconventional means, there would likely be no immediate warning. By the time anyone realized what had happened, it would already be too late. That reality forced a choice. The Department of Defense could accept the risk and rely on detection and treatment after exposure, or it could attempt to reduce the risk in advance. From a planning perspective, the answer was obvious. Prevention, even imperfect prevention, was preferable to reaction. Anthrax vaccination entered the conversation as one of the several countermeasures, alongside gas masks, alarms, and protective gear. But unlike equipment, vaccination had to happen before deployment. Once troops were in theater, mass immunization was impractical. That meant decisions had to be made quickly, under pressure, and with incomplete information. Some units were vaccinated, others were not. The rollout was uneven, limited by supply, logistics, and uncertainty over necessity. At that stage, the program was still framed as a precaution, not a mandate. The vaccine was offered to specific units deemed at higher risk, particularly those expected to operate near potential delivery systems. Even then, cracks were already forming. Reports from the field described confusion over schedules, side effects, and documentation. Medical officers were tasked with administering a vaccine most had little experience with. Service members were told the shots were safe and necessary, but explanations were brief and questions were often brushed aside. There was no time for extended dialogue. War does not pause for informed consent briefings. Complicating matters further was the fog of intelligence. Threat assessments shifted constantly. Alarms went off, then were dismissed. Intelligence suggested biological weapons one day and walked it back the next. Troops trained for chemical attacks that never came. Protective gear was worn, then discarded. The psychological strain was constant. When the war ended quickly and decisively, many questions went unanswered. No biological attack had occurred. No anthrax clouds rolled across the desert. For some, that outcome retroactively justified every precaution taken. For others, it raised an uncomfortable possibility. Had the risk been overstated? That question would linger. In the immediate aftermath, attention shifted to other concerns, unexplained illnesses, environmental exposures, and what would later be grouped under the umbrella of Gulf War health issues. The anthrax vaccine was not yet at the center of that conversation, but it was no longer invisible either. It had entered the bloodstream of military policy, and once there, it did not leave. The Gulf War did something subtle but lasting. It normalized the idea that biological threats justified extraordinary preventive measures, even in the absence of direct evidence. It established a precedent. Uncertainty alone could drive medical policy. For planners, that lesson was clear. For service members, it was less so. As the 1990s unfolded, the absence of an anthrax attacks did not diminish concern. In some ways, it amplified it. If the threat had existed once, it could exist again. If the vaccine had become useful as a precaution before, why not formalize it? The logic was internally consistent. It was also increasingly detached from the original context in which the vaccine had been developed. The Gulf War had ended, but the policy momentum it created had not. What began as a limited wartime precaution was about to become something far more rigid and far more controversial. By the late 1990s, the question inside the Department of Defense was no longer whether anthrax posed a threat. That had been settled. The question was whether uncertainty itself justified compulsion. In 1998, the DoD formally launched the Anthrax Vaccine Immunization Program, better known as AVIP. What had once been a limited situational countermeasure was transformed into a force-wide policy. The goal was explicit: vaccinate essentially the entire active duty force on a fixed schedule, regardless of assignment, location, or immediate risk. This was not framed as an experiment. It was framed as readiness. The logic was straightforward and bureaucratically sound. If anthrax was a potential battlefield weapon, then every service member was potentially exposed. If protection could be achieved in advance, then waiting for deployment-specific decisions only created gaps. Standardization eliminated uncertainty. But standardization also eliminated choice. Under AVIP, the vaccine was no longer offered. It was ordered. Service members were scheduled for a series of injections and boosters. Refusal was treated not as a medical decision, but as a disciplinary issue. Disobeying the orders carried the same consequences as refusing to deploy or ignoring a lawful command. For many, the shots were an inconvenience. For others, they became a line they were unwilling to cross. The reasons varied. Some had experienced adverse reactions to earlier doses. Others questioned the necessity of a vaccine tied to a threat that had never materialized. Some raised concerns about licensing, side effects, or long-term risks. A smaller number objected on principle, arguing that compulsory medical intervention without clear evidence crossed an ethical boundary. The institution did not differentiate between those reasons. From the command perspective, compliance mattered more than motivation. Military discipline does not function if orders are subject to individual negotiation. Once AVIP was declared mandatory, the chain of command closed ranks around it. Briefings emphasized safety and necessity, but they were rarely detailed. Medical personnel were often caught in the middle, tasked with enforcing a policy they had not helped design, using talking points rather than data. Questions about licensing and scope were deflected upward, where answers were slow or non-existent. Tensions escalated quickly. Service members who refused the vaccine faced administrative punishment, loss of rank, or discharge. Some were court-martialed. Careers built over decades ended over a syringe. In many cases, the refusal itself became the offense, independent of any demonstrated harm or operational impact. This was a sharp break from past practice. Historically, the U.S. military had exercised caution around compulsory medical interventions, particularly when they involved investigational products. The legacy of Cold War testing and its aftermath still lingered. AVIP pushed against that institutional memory, relying on legal interpretations that framed the anthrax vaccine as fully licensed and therefore exempt from informed consent requirements. That interpretation would soon be challenged. As AVIP expanded, so did scrutiny. Advocacy groups, veterans organizations, and individual service members began asking questions that had never been publicly tested. Was the vaccine licensed for inhalational anthrax? Did its approval cover its intended use? What legal protections existed for those ordered to take it? The answers were not as clear as the policy suggested. Internally, the DoD maintained that the vaccine was safe, effective, and necessary. Externally, skepticism grew. Media coverage amplified individual cases of adverse reactions and disciplinary actions. What had been a technical force protection measure became a public controversy. The program's rigidity left little room for nuance. Medical waivers were rare, appeals were slow, trust eroded on both sides. Service members felt coerced, leadership felt undermined. Once that dynamic sets in, it becomes self-reinforcing. Compliance achieved through punishment does not generate confidence. It generates silence. Questions go unanswered, not because they are resolved, but because asking them carries consequences. By the end of the 1990s, AVIP had succeeded in one narrow sense. Millions of doses had been administered. But it had also created something the program was never designed to handle, a growing population of service members who felt they had been ordered to accept risk without recourse. That population would soon collide with the legal system. And when it did, the vaccine itself would no longer be the central issue. Authority would be. Once the anthrax vaccine moved from limited use to mass administration, something unavoidable happened. Scale exposed friction. A medical intervention given to a few thousand people can absorb uncertainty. Given to hundreds of thousands, it cannot. Patterns emerge, outliers multiply, systems designed for routine care begin to strain. Officially, the majority of reported reactions to the anthrax vaccine were mild and temporary. Soreness at the injection site, swelling, fatigue, low-grade fever. These were consistent with many other vaccines, and the Department of Defense emphasized that similarity repeatedly. For most recipients, the experience ended there, but not for all. As the program expanded, reports of more severe reactions began to surface. Persistent joint pain, neurological symptoms, chronic fatigue, autoimmune-like conditions. In isolation, each case could be explained away. In aggregate, they became harder to dismiss, yet still difficult to prove. That distinction mattered. The military's medical reporting infrastructure was not designed to resolve long-term, ambiguous outcomes. It was built to treat acute injury and illness, return the service member to duty, and move on. When symptoms lingered without clear diagnostic markers, the system faltered. Reporting itself became a barrier. Service members experiencing problems after vaccination were often evaluated within the same command structure that enforced compliance. That created an inherent tension. Seeking medical attention risked being labeled non-deployable. Reporting adverse effects risked being perceived as resistance to the program. In a culture that rewards resilience and discourages complaint, many chose silence. Others did not. Those who pushed forward encountered another obstacle: documentation. Adverse events had to be recorded, categorized, and linked to vaccination within strict parameters. Delays mattered. Incomplete records mattered. Symptoms that did not fit predefined categories mattered. If a reaction did not occur within a specific time frame or did not match expected patterns, it was often excluded. The system was not necessarily malicious, it was procedural. But procedure has consequences. The DoD relied heavily on passive surveillance systems to track vaccine safety, systems that depend on consistent reporting and follow-up. Critics argued that these systems undercounted adverse events, particularly those with delayed onset. Supporters countered that without objective markers, correlation could not be mistaken for causation. Both positions were technically correct. Neither resolved the lived experience of those affected. Compounding the problem was inconsistency across units and services. Medical officers varied in training, familiarity with the vaccine, and willingness to attribute symptoms to it. Some documented aggressively, others reassured and moved on. The result was fragmented data, insufficient to establish clear trends, but sufficient to fuel distrust. That distrust spread quickly. Service members compared notes. Stories circulated informally, amplified by early internet forums and veterans networks. Official reassurances competed with peer testimony, and for many, personal experience outweighed institutional messaging. Once trust begins to erode, data loses persuasive power. The military's response focused on reassurance and continuation. Studies were cited, safety profiles were emphasized. The logic was consistent. Halting a force protection program based on unproven claims would expose the entire force to unacceptable risk. From a strategic standpoint, that argument made sense. From an individual standpoint, it felt dismissive. Those who believed they had been harmed found themselves in a bureaucratic limbo. Their symptoms were real, but their cause was unacknowledged. Medical care addressed effects, not origins. Compensation required proof that could not be produced. This is where the controversy deepened. The debate shifted from safety to credibility, not just because the vaccine caused harm, but whether the system was capable of recognizing harm even if it did. Every denied claim reinforced suspicion. Every undocumented case widened the gap between official narrative and personal reality. By the early 2000s, the issue was no longer confined to medical journals or command briefings. It had become legal. Service members began challenging the program not on health grounds alone, but on regulatory and statutory ones. If the vaccine was as safe and necessary as claimed, then why were questions discouraged? If adverse reactions were rare, then why was acknowledgement so difficult? And if the program was lawful, then why did it feel immune to scrutiny? Those questions would soon leave the clinic and enter the courtroom. And once that happened, the foundation of the entire program would be tested, not by symptoms, but by statute. For years, the Department of Defense defended the anthrax vaccine immunization program on a single, critical premise. The vaccine was fully licensed, lawful, and therefore exempt from informed consent requirements. That premise would not survive contact with the courts. At the center of the controversy was a deceptively narrow question. What exactly had the vaccine been approved to do? The answer depended not on policy statements or military necessity, but on regulatory language issued decades earlier by the Food and Drug Administration. The anthrax vaccine's original license, granted in 1970, approved it for protection against anthrax. That phrasing had gone largely unchallenged for years because the vaccine's use was limited and uncontroversial. But once the DoD began mandating it for protection against inhalational anthrax from weaponized spores, critics argued that the original approval no longer cleanly applied. That distinction was not semantic, it was legal. Under U.S. law, service members can be ordered to take licensed vaccines without informed consent. They cannot be ordered to take investigational drugs or products used outside their approved scope unless specific waivers are granted by the President. If the anthrax vaccine was not licensed for inhalational exposure, then AVIP rested on shaky legal ground. That argument gained traction quickly. In 2003, a group of service members and civilians challenged the program in federal court, asserting that the vaccine was effectively being used off-label and therefore unlawfully mandated. The case forced the FDA to clarify what it had actually approved and when. What followed exposed a vulnerability the DoD had not anticipated. The FDA attempted to retroactively affirm that the vaccine's license covered inhalational anthrax, relying on historical records and expert interpretation. Critics countered that the agency was rewriting history to support an active military program. The issue was no longer just about the vaccine. It was about regulatory process and administrative authority. In 2004, a federal judge issued a preliminary injunction halting mandatory anthrax vaccinations. The ruling did not declare the vaccine unsafe. It did not rule on medical efficacy. It focused narrowly on procedure, finding that the FDA had not followed proper rulemaking processes when asserting the scope of the vaccine's approval. For the first time, AVIP stopped. The pause sent shockwaves through the military. A program framed as essential to force protection had been suspended not by Congress or the Pentagon, but by a court insisting on regulatory compliance. Service members who had refused vaccination and been punished watched the program grind to a halt, their cases suddenly reframed in a different light. The DoD responded by adjusting course. Mandatory vaccinations were suspended, but voluntary administration continued. Simultaneously, the FDA initiated a formal rulemaking process to explicitly classify the vaccine as effective against inhalational anthrax. Public comment was solicited. Scientific evidence was reviewed. The administrative boxes that had been skipped before were now checked under intense scrutiny. In 2005, the injunction was lifted. The FDA finalized its determination. The DoD resumed mandatory vaccinations. On paper, the issue was resolved. In practice, the damage was already done. Service members who had been disciplined for refusing the vaccine during the injunction period found themselves in a legal gray zone. Some sought redress, others did not. Careers that had ended were not automatically restored. Punishments already imposed were rarely reversed. The institution moved forward, but it did not look back. The episode exposed a fundamental tension between military authority and civilian oversight. The DoD had acted in good faith, according to its own logic. It identified a threat, selected a countermeasure, and enforced compliance. The courts did not dispute the threat. They disputed the process. In doing so, they reminded the military that even in matters of national security, regulatory shortcuts carry consequences. For many service members, that distinction felt hollow. They had not refused the vaccine because of regulatory nuance. They had refused because they believed the order was wrong, unsafe, or unjustified. Seeing the program halted on legal grounds validated their skepticism, but it did not undo the personal cost. For others, the legal battle reinforced the opposite conclusion. If the issue had been procedural rather than scientific, then the vaccine safety stood uncontested. The controversy, in their view, had been manufactured. Both interpretations coexisted uneasily. What could not be undone was the erosion of trust, the revelation that the program's legal foundation had been contested and temporarily overturned, confirmed fears that policy had outpaced process. Once that realization set in, confidence could no longer be restored by regulatory filings alone. The anthrax vaccine controversy had crossed a threshold. It was no longer about compliance or side effects. It was about legitimacy. And legitimacy, once questioned, does not recover easily. The next collision would not be between the DoD and the courts. It would be between authority and conscience, played out one service member at a time. When the anthrax vaccine debate moved beyond clinics and courtrooms, it entered a far more personal arena, individual conscience under command authority. For the military, obedience is not optional. Orders are presumed lawful unless clearly illegal, and the burden to challenge them is high. That structure is not incidental, it is foundational. But AVIT placed that structure under unusual strain. The order was medical, the consequences were disciplinary, the uncertainty was unresolved. Some service members complied, despite misgivings. Others did not. Those who refused the vaccine were not a single block. They included pilots, medics, enlisted personnel, and officers. Their objections varied. Some cited adverse reactions, others raised concerns about licensing and legality. A small number objected on ethical grounds, arguing that compulsory medical intervention without clear necessity violated their understanding of service. The system did not distinguish among them. Refusal was treated as refusal. Insubordination followed a predictable path: counseling, non-judicial punishment, administrative separation, or court-martial. In several high-profile cases, service members were imprisoned. Careers ended abruptly, security clearances vanished, pensions evaporated. From the command perspective, this was enforcement, not retaliation. Orders had been issued, compliance was required. Allowing individual dissent would fracture discipline and set a precedent the institution could not afford. From the individual perspective, it felt like coercion. This is where whistleblowers entered the picture, not in the cinematic sense, but in the mundane reality of paperwork, affidavits, and testimony. Service members documented adverse reactions, medical professionals questioned reporting practices, lawyers challenged interpretations of regulatory authority. Each action carried professional risk. The courts became a partial refuge. Military judges and civilian courts alike were asked to weigh obedience against legality and safety against procedure. In some cases, judges sided with the institution. In others, they imposed limits. The resulting patchwork of rulings added to the confusion rather than resolving it. One thing was consistent: relief was rare and slow. Even when injunctions halted the program, they did not automatically restore rank, reverse discharges, or repair reputations. The military justice system is forward-looking. It enforces order. It does not easily revisit past decisions, even when policy shifts. That left many in permanent in-between state, neither vindicated nor reconciled. The personal cost extended beyond the individual. Families lost income. Spouses watched careers dissolve over a decision that, in civilian life, would have been considered routine consent. Children absorbed the stress of sudden relocation or unemployment. None of that appeared in policy memos. Inside the services, the message was unmistakable. Disagreement carried consequences. That message had a chilling effect. Fewer service members spoke openly. Questions became private doubts. Reporting declined. Science replaced debate. From an enforcement standpoint, the program stabilized. From a trust standpoint, it fractured further. Moral injury, typically associated with combat decisions, quietly entered the conversation. For some, the injury was not physical. It was the feeling of being compelled to accept risk without acknowledgement, and then punished for resisting. This is the point where the controversy stopped being about anthrax. It became about the limits of authority, about whether lawful orders can still be unjust, about whether institutional necessity excuses procedural shortcuts. These are uncomfortable questions in any organization. In the military, they are existential. The Department of Defense emphasized that no one was above the mission. That message resonated with many. Service requires sacrifice. Risk is inherent. The anthrax vaccine, they argued, was simply another burden borne collectively. But sacrifice assumes reciprocity. When service members believe that the institution will protect them, advocate for them, and take responsibility for imposed risks, sacrifice becomes sustainable. When that belief erodes, obedience becomes transactional and fragile. By the mid-2000s, AVIP continued, but the atmosphere around it had changed. Compliance no longer implied confidence, it implied resignation. The whistleblowers had not stopped the program, the courts had not dismantled it, but together they had exposed a fault line the institution could not fully repair. The consequences of that exposure would not be felt immediately. They would surface later in a different arena, when veterans sought recognition, care, and compensation long after the shots were over. That is where the controversy followed them home. For many service members, the anthrax vaccine controversy did not end with discharge papers or the final booster shot. It followed them home, quietly, and then all at once. Years after leaving active duty, veterans began seeking care for symptoms they could not easily explain and conditions that did not fit clean diagnostic categories. Chronic fatigue, joint pain, neurological complaints, autoimmune-like issues. Individually, none of them were unique. Collectively, they formed a pattern that felt familiar to anyone who had lived through previous exposure controversies. The problem was not treatment, the problem was recognition. Within the Department of Veterans Affairs systems, disability compensation is not based on belief or probability. It is based on documentation, nexus, and proof. A veteran must demonstrate three things: a current condition, an in-service event or exposure, and a clear medical link between the two. For anthrax vaccine claims, that third requirement became a wall. There were no definitive biomarkers for vaccine injury, no single test that could confirm causation years later. Symptoms overlapped with countless other conditions. Medical literature remained cautious, emphasizing population-level safety rather than individual outcomes. In the absence of clear evidence, claims were often denied. Not because the symptoms were fake, because the cause was unprovable. This placed veterans in a familiar bureaucratic trap. They were told their conditions were real, but not service-connected. That they required treatment but not compensation, that correlation was insufficient, and causation could not be established. For those who had already watched the military dismiss concerns during service, the experience felt like repetition. The pattern echoed earlier exposure battles, almost point for point. First came acknowledgement of exposure, then reassurance, then denial of long-term harm, then studies, then time. Anthrax vaccine claims lacked something critical that later controversies would gain: presumptive status. Unlike Agent Orange decades earlier, or burn pits much later, there was no legislative or regulatory framework that assumed responsibility and shifted the burden away from the individual veteran. Each case stood alone. Veterans filed claims, appealed denials, gathered medical opinions, and often lost anyway. Private physicians were hesitant to draw firm conclusions without definitive evidence. VA examiners deferred to existing guidance. Adjudicators relied on the absence of consensus. The result was procedural abandonment. What made this especially painful for many veterans was the contrast with later developments surrounding burn pits. In that case, years of advocacy, media coverage, and political pressure eventually produced presumptive conditions and expanded eligibility. The system, imperfect as it was, acknowledged that waiting for absolute proof had failed too many people for too long. Anthrax vaccine veterans watched that unfold with mixed emotions. On one hand, it validated their broader argument. Exposure-related harm does not always announce itself cleanly or immediately. On the other hand, it underscored how timing shapes justice. Those who fell into earlier controversies often paid the price for institutional hesitation. The VA did not deny claims out of malice, it denied them out of structure. Disability systems are conservative by design. They respond to statute, regulation, and precedent. Without clear guidance, adjudicators default to denial. From the system's perspective, this preserves consistency. From the veteran's perspective, it preserves distance. Many anthrax vaccine claims quietly disappeared into that gap. Some veterans stopped filing after repeated denials. Others pursued appeals for years. A few succeeded on narrow grounds, often tied to secondary conditions or unique documentation. There was no sweeping resolution, no collective reckoning, just attrition. This is where the controversy became less visible but more entrenched. Public attention moved on. New wars began, new exposures emerged. The anthrax vaccine faded from headlines, but not from medical histories. Veterans continued to carry conditions without labels and injuries without attribution. What lingered most was not physical suffering alone, but institutional memory. Veterans who had lived through AVIP recognized the pattern immediately when burn pits entered the conversation. The same language appeared, the same insistence on insufficient evidence, the same reliance on future studies, the same delay. The difference was outcome. Burn pits veterans eventually forced the system to adapt. Anthrax vaccine veterans largely did not. Not because their experiences were less real, but because momentum matters. Political will matters. Numbers matter. Visibility matters. The anthrax controversy fell into an uncomfortable middle space, too large to ignore, too diffuse to resolve. For the VA, that meant continuing to process claims individually, without guidance that would allow for a broader acknowledgement. For veterans, it meant living with the knowledge that their service included a risk that the institution had ordered, but would not fully own. This chapter of the story is not about proving harm. It's about burden. Who carries it when uncertainty cannot be resolved? Who pays when documentation fails? And how long can a system rely on ambiguity before it becomes policy? The anthrax vaccine controversy did not produce a single scandal moment or legislative fix. Instead, it produced something quieter and more corrosive, a cohort of veterans who learned early on that exposure alone does not guarantee recognition. That lesson would resurface again and again in the decades that followed. And it would shape how future controversies were fought, because some veterans remembered what happened when they trusted the process the first time. As the anthrax vaccine controversy widened, the institutional response settled into familiar terrain: studies, reviews, and statistical reassurance. The Department of Defense and public health agencies commissioned multiple analyses to evaluate the vaccine's safety and long-term effects. These studies examined rates of illnesses, hospitalization, and mortality among vaccinated and unvaccinated populations. At the population level, no statistically significant increase in serious long-term health outcomes could be definitively linked to the vaccine. On paper, this should have ended the debate. But statistics do not operate where trust is broken. Population studies are designed to detect broad trends, not individual suffering. They are excellent at answering whether a program is broadly safe. They are less capable of explaining why specific individuals experience persistent symptoms that fall outside of expected patterns. When veterans were told that studies showed no increased risk, many heard a different message: your experience does not count. The timing of these studies mattered as well. Many were conducted years after the initial vaccinations, relying on incomplete records and retrospective analysis. Attrition skewed samples. Self-reporting complicated causation. The longer the gap between exposure and study, the easier it became to dismiss connections as coincidental. Critics argued that the research questions were too narrow. Supporters countered that expanding them risked conflating unrelated conditions. Both positions were defensible. Neither resolved the core tension. What studies could not repair was credibility. The legal battles had already exposed procedural shortcuts. Reporting systems had already failed to capture every case. Punishments had already been imposed. By the time reassurance arrived, it felt retrospective, designed to justify decisions already made rather than inform them. This is the limit of data in institutional crises. Numbers can validate policy. They cannot restore faith once individuals believe that they were ordered to accept risk without transparency or recourse. Even flawless statistics cannot overcome the perception that outcomes were predetermined. For leadership, the conclusion was straightforward. The vaccine was safe enough, the threat was real enough, and the program was justified. For affected veterans, the conclusion was more complicated. Safety at its scale did not erase personal cost. Absence of evidence did not feel like evidence of absence. The studies closed the books administratively. They did not close the case emotionally. That distinction explains why the anthrax vaccine controversy never truly ended. It simply receded, waiting for the next exposure, the next mandate, the next moment when trust would again be tested. And when that moment came, many veterans already knew how the story would unfold. Today, the anthrax vaccine still exists inside the U.S. military, but in a far quieter, more conditional form than it once did. The sweeping force-wide mandate that defined the late 1990s no longer exists. Instead, vaccination policy has narrowed, focusing on specific occupational specialties and deployment scenarios where the perceived risk of exposure remained elevated. The language has shifted from universal requirement to targeted readiness. That change did not come from new scientific breakthroughs, it came from experience. The Department of Defense continues to maintain that the vaccine is safe and effective when used as directed. Regulatory questions have been formally resolved. Legal authority has been clarified. From an institutional standpoint, the controversy is closed. The system functions, the program continues. But closure on paper does not equal resolution in memory. Among service members, particularly those who lived through AVIP at its height, the episode left a residue of skepticism. It became a reference point, something quietly cited whenever new medical directives were issued, not always allowed, but remembered. The military learned operational lessons from the controversy. Communication improved, documentation standards tightened, legal review became more visible. Future medical programs were framed with greater attention to consent language, even when consent was not technically required. These were incremental changes, not admissions of fault. The vaccine itself also changed. Manufacturing processes were modernized, oversight increased, surveillance systems were refined. None of that erased the earlier experience, but it reduced the likelihood of repetition at the same scale. For veterans, however, the present offers little retroactive comfort. Those who suffered adverse reactions, or believed they did, remain largely where they were years ago. Claims continue to be evaluated individually. There is no presumptive status, no collective acknowledgement. Time has not softened the burden of proof. If anything, it has hardened it. This creates an asymmetry that defines the present state of the controversy. The institution has moved on, the individuals have not. In public discourse, the anthrax vaccine rarely appears unless prompted by new exposure debates or historical retrospectives. It lacks the visibility of Agent Orange or burn pits. It occupies a quieter corner of military history, understood by those who lived it, unfamiliar to those who did not. That obscurity is itself a form of resolution. Controversies without clear villains or definitive outcomes tend to fade rather than conclude. They become cautionary tales rather than rallying points. Inside the Pentagon, the episode is remembered as a necessary but flawed response to a legitimate threat. Inside veterans communities, it is remembered as a warning about what happens when urgency overrides transparency. Both interpretations coexist. The question of whether the program was justified depends largely on where one stood when the order came down. For planners facing hypothetical mass casualties, the decision appeared rational. For service members ordered to comply without meaningful explanation or recourse, it felt imposed. That tension remains unresolved because it is not scientific, it is structural. The anthrax vaccine controversy did not end with a recall, an apology, or a policy reversal. It ended with a quiet narrowing of scope and a collective decision to stop talking about it. But the absence of conversation does not mean the absence of consequence. A military cannot function without obedience. Orders must be followed, risk must be accepted, sacrifice is not optional. But obedience has limits, not in discipline, but in responsibility. The anthrax vaccine controversy was never truly about a syringe or a bacterium. It was about what happens when an institution demands compliance without fully accounting for consequence. When urgency outruns process, when trust is treated as automatic rather than earned. Service members were told the vaccine was necessary, lawful, and safe. Many accepted that without hesitation. Others questioned it and paid a price. Years later, the system offered studies instead of answers, procedures instead of acknowledgement. None of that makes the military malicious, it makes them human and imperfect. What this episode exposed is a recurring pattern. Exposure controversies are rarely resolved in real time. They are managed, minimized, and studied until attention shifts elsewhere. Veterans carry the uncertainty while institutions wait for clarity that may never arrive. Burn pits followed the same arc. So did Agent Orange. So did radiation testing. The details differ. The structure does not. The lesson is not that medicine cannot be trusted or that authority is inherently abusive. It is that trust cannot be compelled. It must be maintained, especially when orders extend beyond the battlefield and into the body. If the anthrax vaccine controversy accomplished anything lasting, it was this. It forced future policymakers to reckon, however quietly, with the cost of ignoring that truth. Because the next exposure will not ask permission either. And when it comes, veterans will remember who carried the burden last time. I'm Dave. I appreciate you watching. Please like, subscribe, comment, and share. And until next time, stand tall.
Oh, Dave.